Good morning, everyone. What we'll be doing today in these next few sessions and tapes is review a number of internal medicine cases in the format that you'll see them on Step 3 on the USMLE. And we'll talk about how to think through the case, how to dissect and analyze a case in a very efficient manner, so you do it without spending a great deal of time on each case. And we'll talk about it in sequence, talking about how you establish a differential diagnosis. That will lead you to what diagnostic tests you will order, and then we'll follow that up with what treatment you would order, and in what sequence, what sense of priorities you should have for the different diagnostic tests and treatment plans. After we do that, we'll review the topic in some detail before going on to the next case. Now, as you know, for Step 3, computer case simulations, which I'll refer to from now on as CCS, is now at least 1/4 part of the exam, and it's not clear that it will become more or less over the future. Right now it's 1/4 or less, and what I will do through these cases as a teaching tool is go through the cases and make references to the CCS format, as in what would you do next here, what test would you order here, what IV would you put in, what kind of fluids would you want, etc., to have you think in that manner so that when you come to the CCS and you're left in this wide open field where you can order any one of 2,500 orders, you'll have a sense of how to think about it in a logical way. So let's move to the first case. And the chief complaint is chest pain. Now, in the CCS, what you'll get on the first screen, as you probably know, is a one-line complaint, and then followed by the vital signs, the history, and then you have to start choosing what you want in the physical examination and any orders you would like. But for the purpose of these cases, it's all on one screen. But let's think about a 68-year-old man comes to the emergency room with 1 hour of severe, sharp, substernal chest pain. What I'd like to do as we go through these cases today is the following. I want you to get into the habit of reading through these cases as if you were on the exam. On the exam, I'm not going to be standing there reading these things out loud in front of you, much to your relief. And you're going to be reading through these to yourself, and I want you to get in the habit of reading to yourself and making mental bookmarks about what's important in the case and what's not. And of course, you'll have a pad where you could jot things down next to your computer when you're taking the exam. And then what I'll do is, after you've had a chance to read the case to yourselves, what I'll do is I'll say, why don't we hit the pause button now? You'll read the case. When you finish reading the case, I'll say, hit play button. And then I'll read the case out loud and talk you through how I think about working up these cases and what's meaningful, what's important in these case scenarios. So the first question, a 68-year-old man comes to the emergency room with 1 hour of severe, sharp, substernal chest pain. At this point, I would have you pause button and read the question to yourself. When you're finished with it, you'll hit the play button, and I'm going to continue. There is no radiation of his pain. He is somewhat short of breath, but is not diaphoretic or nauseated. So right away, I should already have a tight differential diagnosis. The key to Step 2 or Step 3 or in real life is not to, establish as broad a differential diagnosis as possible. To the contrary, you want to be very practical and keep the differential diagnosis list short. So now I have a man who's 68, substernal chest pain, no radiation, and he's short of breath, but he's not diaphoretic or nauseated. What should be on the top of my list? Any 68-year-old man who's coming with chest pain, I'm going to put coronary ischemia at the top of my list. The pain occurred while he was helping his son move his furniture into his new apartment. Now, how does this help me? This is exertional chest pain. Again, a very good clue that this is probably coronary ischemia. There have been no prior episodes of pain, and he is generally healthy. He is a non-smoker whose father died at age 67 of heart trouble. Now, he's a non-smoker, so he doesn't have that risk factor. His father had coronary disease at 67, which strictly speaking is not considered a hard risk factor for coronary ischemia. Rather, when we're talking about a family history, we're talking about a family history with a coronary ischemia event, whether it was onset of angina, myocardial infarction, or perhaps surgery for coronary ischemia, occurred before the age of 60 in men or in premenopausal women. But they're trying to lead me on that this patient has a family history of some heart disease. Again, that's not a hard finding. He has no allergies, and his only medications are vitamins and ranitidine for indigestion over the last 2 months. Now, is this important, or is this something totally irrelevant? Well, I think if you're told someone with chest pain is having indigestion and is using ranitidine, an H2 receptor antagonist, that at least the thought of gastroesophageal reflux disease or some esophageal process should come to mind. On the other hand, that wouldn't be exertional, and the 68-year-old, I'm much more concerned about making the diagnosis of coronary ischemia than I am of making the diagnosis of GERD. So right now, as I'm about to finish the question, the patient is still in pain. I think he has coronary ischemia, and I think that it's ongoing pain because he came to the emergency room with it. He's had it for 1 hour, and the pain is still there. So I'm concerned that this man has a prolonged episode of angina, and in the setting of the duration of the pain, 1 hour, I'm concerned that this man might be having a myocardial infarction. Do I know that for sure at this point in the question? No. But that's by far my number one on my differential diagnosis list. What might be number two? We'll talk about it after we get some more information. But again, most of the time, you'll be able to make a very short and very accurate differential diagnostic list based just upon the history. So I would put myocardial infarction, number one, number two, an unstable anginal episode. Okay? And we'll expand that list as we go through the case. Now, on physical examination, imagine if this was CCS. The next screen you will have are the vital signs. And at this point in CCS, those first three screens, history, vital signs, and then the detailed history, you have no control over making orders or switching the routine there. You'll have those first three slides. And by the time you finish those three slides, you should have a very good idea or the single best diagnosis firmly in mind. There's a separate tape on the process, the techniques that I suggest of working through the CCS, literally line by line, screen by screen. I won't reiterate all of that now, but I think it's essential that you go through that tape and then use that to practice the USMLE released cases on the computer case simulations. But what I emphasize there and what I will emphasize here is you should ask yourself, firstly, especially in the CCS and even here, is this an acute emergent problem for which I have to do stuff, whatever that stuff might be, right away? Or is this more of a chronic, stable problem, in which case I'll be a little bit more leisurely? Why is that important? Because after you get that history screen on the CCS, then you don't get an automatic physical examination. You could actually stop there and order things before you even do a physical. I mean, if a patient is cyanotic and barely breathing, you'll put oxygen on even before you do a physical examination. When you order the physical, you have to tell the computer what you will order on that physical examination. Do you want to do every possible system? Okay, and obviously not. If someone's very acute, you're not going to do a detailed lymph node exam. You're not going to do a breast exam, a rectal examination. All right? So you have to think about, is this an acute, emergent problem about which I'll have to act even before I have a great deal of information, or is this a chronic, stable sort of problem, in which case I'll have a little bit more time to think about tests to order, more information to get from the physical than I would in an acute situation. So the physical examination starts with the vital signs in these cases, and on the CCS, you'll have that one line of the initial chief complaint, then the vital signs. Okay? So in the vital signs, that'll give me a very, very important clue whether this is acute, emergent, or chronic and stable. Now, from that history, I already know that this is an acute, emergent problem. And again, on the CCS format, you're not going to have that much history before you get the vital signs. So you'll have to make your decision about acute versus chronic, stable versus emergent, based upon the one line and the vital signs before you get the detailed information. The temperature is 37.4. That's not very impressive. His pulse is 110. That is impressive. If this is coronary ischemia, I want to make sure that I'm not missing any other diagnoses. Tachycardia in the setting of coronary ischemia is a very worrisome sign. It implies a very high adrenergic tone. The blood pressure is in a stable range, and the respiratory rate is 22. He's mildly tachypneic. Now, on the physical examination, if this was CCS, I get to choose what I would want on that physical examination. You say, well, why don't I examine everyone in detail, get the most possible information? Because, again, think of this if it was CCS, as opposed to this sort of typical single best answer. If this was CCS, the cost of ordering more things on the exam is the cost of time. Someone's in fulminant pulmonary edema or massive GI bleeding, and you're spending leisurely time doing a very detailed 40-minute exam. Your patient will literally die on the exam. They'll say the patient has stopped breathing while you're still doing this detailed physical. And you should know the, quote, cost of the various parts of the physical examination, whether it's a 1-minute feature or a 2-minute feature, and you'll again get that by working through the computer case simulations that the USMLE distributes. So this patient, his head and neck exam is normal. His lungs are clear bilaterally. The pain is not reproduced by palpation. So right away, I don't think this man has costochondritis. The sensation of the reproduction of pain by pressing on the costochondral joints, it does not sound like that from the history anyway. Cardiovascular exam, he's tachycardic, which I knew from taking his pulse. He has no murmurs, no gallops. That's useful information. It tells me that he hasn't developed an acute mitral regurgitation, perhaps from ischemia. He doesn't have a gallop of S3, which would imply left ventricular failure, overload failure. And he has no S4, which would imply an acute hypertensive or a diastolic dysfunctioning left ventricle. The abdomen is unremarkable, and the extremities show no edema. So there's no evidence here of a man having a myocardial infarction with CHF. It sounds like a man's having a myocardial infarction. The differential diagnosis, well, unstable angina, that's a very good possibility. If the pain were to stop as soon as he arrives in the ER, then it would be 1 hour of pain. And let's say he doesn't have the other diagnostic features of myocardial infarction, which we'll talk about in a few minutes. This will end up being called unstable angina. If it is prolonged, so let's talk about the distinction between unstable angina and acute MI. If it's prolonged, then I'll start thinking about acute MI, and I'll need to have 3 features to make me think of acute MI as the real diagnosis. Number 1 is I want to get the appropriate history. I mean, if someone comes in and their ankle hurts, I'm not going to put MI anywhere on my list. I'm not even going to do the next diagnostic tests, which are going to be an EKG and cardiac enzymes. Now, you need to at least have 2 out of those 3. There are people who have very impressive EKGs and very high CPK or troponin levels, which we'll talk about in a moment, but their story is atypical. That doesn't matter. If you have 2 out of these 3 features, then you probably have an MI on your hands. We'll talk a little bit now about dissecting aortic aneurysm. You should always have that somewhere on your list in someone who's presenting with severe chest pain and maybe hemodynamically unstable. Why? Not because it's common. For every MI, for every dissecting aortic aneurysm you'll see in real life, you'll see 500 MIs. Fortunately, dissecting aortic aneurysm is nowhere near as common as an MI. But you'll see it frequently enough on the board that you need to know about it because it fits the category of one of those things that you cannot afford to miss. Now, the boards are testing now, as opposed to earlier years, more and more on common diseases that you need to know on everyday level as you're an intern during your residency. I mean, that's after all when this test is designed to be taken. While you're an intern, managing your own patients with superior or more senior, maybe not superior, but more senior residents and attendings in the hospital, and you're going to be responsible yourself for managing the patient, diagnosing, treating, and writing the orders. Okay, so you're ultimately going to need to know which med, what dose, what route of administration. So in the dissecting aortic aneurysm, that falls into the category, as I said, of something you cannot afford to miss. Even though it is uncommon, if you miss this diagnosis, great harm or death will come to this patient. So why do I think of dissecting aortic aneurysm? I will always think of it in someone who has chest pain that is impressive and maybe hemodynamically unstable, but doesn't have features to make me strongly think of myocardial infarction. Namely, he has this terrible chest pain, tachycardic, maybe hypotensive, maybe hypertensive. But on the other hand, the EKG looks strangely normal. And if it was an MI with that much pain, I would expect to see a number of ischemic changes. So if I have someone who has a good story for an MI or a fair story for an MI, and the question makes it clear that the EKG does not show me ischemia, they want you to think about dissecting aortic aneurysm. Very often they'll make it so simple for you that they'll use the word of it's a tearing or shearing pain rather than a squeezing type of pain that you see with coronary ischemia. And anytime you see the word tearing on USMLE, I bet there's going to be a choice in there of aortic dissection. Pericarditis, let me back up for a moment, dissecting aortic aneurysm. When you do suspect it, based on the history, the physical, in which case you might see a loss or asymmetry of pulses, upper extremities or lower extremities, or between the upper extremities and lower extremities, they want you to move quickly on that patient. And what you would do then is a angiogram, all right, to see if there is a dissection, an angiogram of the aorta. If in that question it's a case where you're suspecting an aortic dissection in the thorax rather than a type B dissection, which means anything other than the ascending aorta. If it's a type A dissection, meaning ascending aorta, if they give you a choice of a transesophageal echocardiogram, that's a very good choice, and I would probably even pick it before an angiogram because it is less invasive and it can be done very quickly, whereby a scope is passed into the upper esophagus. It's localized right next to the aortic arch where the dissection is suspected, and you can actually see the intimal tear or flap in the dissection. They probably won't ask you to choose between a TEE, transesophageal echocardiogram, and an angiogram. It's a little bit picky, and either one could be correct. They'll probably give you a aortic angiogram, and that would be the right choice. Another less favorable option, but also would not be a wrong answer, would be a dynamic CT of the chest with contrast. That, again, is less invasive than an angiogram, and, on the other hand, a little less likely to make the diagnosis. And I think they'll give you one of those three and not ask you to choose between those three. And that would be first choice aortic angiogram as the most direct but most invasive test. Number two, a transesophageal echocardiogram, somewhat invasive, less invasive than an angiogram. And number three, a dynamic CT, which is the least invasive but probably going to miss the smaller dissections. So I will suspect it by the history, the EKG being normal or near normal, and someone with bad chest pain, and I'll do one of those diagnostic tests. If it is confirmed, what I'll try and do is control the blood pressure, not to the point of very low, because we want to maintain some perfusion pressure. On the other hand, you don't want the blood pressure really high because that will cause greater traction on that tear and extend the dissection. If the patient has a clearly demonstrated dissection in the question, the next step is emergent surgery. Okay? So in dissection, suspect on the history, normal EKG, do the right diagnostic test, aortic angiogram, go to surgery if it's there. Pericarditis. That pain, what does that pain sound like? Well, first of all, it sounds nothing like the pain in this man. But this gives us an opportunity to talk about the patient with pericarditis. What would you see in the history that the question describes? You would hear a type of chest pain that is pleuritic in nature. With movement or with deep breath, the pain is worse because the pleura is being irritated around the heart. Remember, there's a parietal pleura and then a visceral pleura. And when those two areas get irritated, as there's movement between those two layers of the pericardium, that's when you're going to have pain. If the patient lies more still, they're less likely to have pain. If the patient lays forward and gets the heart off of the posterior thorax, they might feel better. But it's positional, and it might be pleuritic in terms of more pain with deep breaths. Pericarditis on physical, you're going to listen to the heart very carefully for the signs of a rub. What would a cardiac rub sound like? Well, if you took your hair right near your ear and rubbed it like that, that sound you hear is basically reproducing the sound of a pericardial rub, or in the case of a chest pleura, a pleuritic rub. So that would be there on the physical, but very often they're hard to hear. And I'll give you a very clear case of what sounds like pericardial type chest pain on the history. The physical is not remarkable, and then they'll show you the EKG. What do you see on the EKG for pericarditis? You'll see very characteristic ST elevation. When they say ST elevation, I thought I see that with coronary ischemia. Well, you do. But in coronary ischemia, the ST elevation tends to be more localized or solely localized to those leads where the patient has their coronary ischemia. For instance, a lateral wall MI leads 1 and L. Limb leads 1 and L, AVL. If it's an inferior wall MI, leads 2, 3, and F. An anterior wall MI will be distributed among the chest leads. On the other hand, pericarditis will show you ST elevations in all the chest leads, and instead of having a instead of having the ischemic type ST changes, where the ST changes are convex. You get the picture. Is this convex or concave? I'm not quite sure. This is convex. From the S to the top of the T, it's shaped like that. Okay? As opposed to the ST elevation on pericardial ST elevation, where it's shaped concave. And the ST elevation is more importantly than the shape, because there's a lot of gray zone there, is that the pericardial EKG changes of ST elevation are diffuse across the pericardium. A more subtle sign you'll see in pericardial EKG changes is of ST depression. which you don't see with coronary ischemia. How do you treat pericarditis? And what are the causes? Well, the causes very often, if it's an outpatient, it's a viral pericarditis, often in the setting of other signs and symptoms of an upper respiratory tract infection. We'll talk about pericarditis in the setting of an MI. It's very rare that you'll see in real life or on USMLE the patient has pericarditis from metastatic disease. What cancers would metastasize to the heart? Easy to remember. Just think about what lives around the heart, and that's the breast and that's the lung. Women with breast CA can have metastatic disease to the pericardium. Women or men with lung cancer can have metastatic disease to the pericardium. But that'll be clear that a patient has widespread cancer at that point. Pericarditis, again, the history, the physical of the rub, the EKG changes, ST elevation and PR depression, diffuse ST elevation, and the treatment for pericarditis will be aspirin or NSAIDs. Okay? And we'll talk a little bit more about pericarditis in the setting of MI in a few slides. Esophageal spasm, what will you look for in the history? Pain that is a squeezing pressure, just like the pain of coronary disease. That point will not help you distinguish between the two, but there is no other signs in the question, signs or symptoms to make you think of coronary ischemia. It's certainly not related to exertion, but it can be related to meals. Not always. Some people have esophageal spasm, and it just happens randomly. But they'll probably give you a sense that this is a patient with a history of esophageal problems in the past, most typically gastroesophageal reflux disease, or GERD. The physical exam of esophageal spasm will be perfectly normal. The vital signs will be perfectly normal. The EKG will be normal, or maybe some very minor ST T-wave changes that are very nonspecific. And the diagnosis of esophageal spasm is made with which diagnostic test? You would do an esophageal manometry, whereby you put down a thin catheter in the esophagus and measure pressure measurements with the patient taking what's called a dry swallow, like that, and then giving the patient a sip of water, and then measuring the pressure movements with a wet swallow. And that will show you very high pressure contractions in the mid-esophagus in a non-peristaltic fashion. But again, far, far less likely than coronary ischemia in a patient such as ours. And again, remember, I'm doing this differential diagnosis list, which is fairly long, purely as a teaching tool. If all of these things you're considering all these things on an exam, you're doing the wrong thing. You're spending too much time on very unlikely diagnoses. And again, your job in reading the history is to narrow that differential diagnosis, preferably to 1, maybe 2 or 3. Pulmonary embolism, that's again not only a fairly common disease, but a disease where it falls into the category of you cannot afford to miss this disease. So I should think about pulmonary embolism in many situations. This doesn't sound like. This is not that kind of pleuritic chest pain that you see with pulmonary embolus. The patient has no risk factors for pulmonary embolus. He's not immobilized. He has no history of venous stasis or congestive heart failure. He's not post-op and laying in bed. He hasn't recently had a hip fracture and is laying in bed in traction or, again, immobilized. And he has no history that I can tell by either the history or by looking on the physical examination of a hypercoagulable state. So PE would be low on my list. I'm going to talk about PE again later, so I won't go into details with the physical exam or the diagnostic tests or therapies. Musculoskeletal, well, here we did make a direct reference to it in the history or on the physical, where we said there's pain. The pain is not reproduced with external pressure. So I don't think this is costochondritis. There's nothing in the history whatsoever to suggest perhaps he fractured a rib. Right? Again, we don't want to start thinking about extraneous things that are not suggested in the question. Pancreatitis, well, this is thrown in here because some people with pancreatitis have their pain a little higher than the mid-epigastrium and it goes into the chest. But there you'll hear a history of nausea and vomiting. Epigastric tenderness is almost always present, even if the patient senses the pain up here. And you'll probably get information in the question that makes you think about the possibility of pancreatitis. Namely, is it an alcoholic patient? Is it a patient who might have gallstones and therefore gallstone pancreatitis? Or is it someone who's on a medication that might cause pancreatitis? None of these are remotely relevant to this question. Pneumothorax, again, a condition you can't afford to miss. How would the patient present? It would be sudden shortness of breath, more than the feeling of a chest pain. You do get chest pain with pneumothorax, but there the chest pain is pleuritic in nature. This patient does not have pleuritic chest pain. He has a typical anginal type of chest pain. A pneumothorax, if I suspected from the history. I'll listen very carefully on both lung fields, and what I'll hear is a loss of breath sounds on the side where the lung has collapsed. Very simple to visualize, is if one lung collapsed, the airway spaces are collapsed, and that area lateral to where the lung has collapsed will not have any breath sound. And that area will look purely black on the chest x-ray because all the lung markings, again, have collapsed, whether it's on the left side or on the right side. And again, that's the test I'll do, is a chest x-ray, and it'll show me a black space where there should be lung markings. And the immediate treatment there is if it's a clinically significant pneumothorax with significant hypoxia or change in vital signs, the chest tube insertion will be potentially life-saving. So we've gone through a number of different entities that can present with chest pain. But again, this should not be going on your head. We spent about 30 minutes, and if you're on question number 1, 30 minutes into the exam, it's going to be a very, very long day for you. Or maybe, in fact, a very short day. Now, how will we work up, back to our patient, how will we work up the patient who we suspect has coronary ischemic disease? Now, if this was CCS, here you're on your own. Okay, you've had the history, the one-liner, you've had the vital signs, you've had the physical, and now the screen says, what do you want to do here? And right now, what do you want to do here? If this was a CCS question, you would want to get an EKG, practically. Again, remember, a lot of those other etiologies of chest pain would have normal EKGs or different kinds of EKGs. So we do an EKG, and we find the patient has sinus tachycardia, which is not surprising. He had a heart rate of 110. We were told it was regular. And he has 2 millimeter of ST elevations in leads V2 through V4. Sounds like an anterior wall myocardial infarction. What are the signs and symptoms, what are the kind of signs, or what is the sequence of development of EKG change in someone with myocardial ischemia? Well, this is exactly the sequence. Number 1 is you'll see the ST elevations in the leads corresponding to the region of the heart, we already discussed this, where the ischemia is ongoing. Number 2, you'll start having the formation of Q waves, and we consider Q waves significant if, number 1, they're new, and number 2, if they're at least 1 box wide, which means 0.04 seconds in duration. And of course, you can't read those if the patient has a pre-existing left bundle branch block. So, third, what we'll see is inversion of those originally very upright T waves. They will begin to invert, usually in a symmetric fashion. So it's ST elevations, Q waves, and inversion of T waves. Once the Q wave is there, traditionally we've taken that as a sign, a signal that this patient has already had completed a transmural infarct. It turns out that transmural infarcts can occur without the development of Q waves, and some patients develop Q waves and don't have true transmural infarction. But traditionally we've thought about it in those terms, that there's a transmural infarct when a Q wave appears, and when there's no Q wave but otherwise a good story and cardiac enzymes positive for an MI, if there's no Q wave, we might call that a subendocardial myocardial infarction. And again, we should get away from those terms because from the EKG alone, we don't know the depth of the infarction. So we should call it either a Q wave infarction, because that we have right in front of us on the EKG, or a non-Q wave infarction. Next, what am I going to do? What am I going to order? All right, if this was CCS, got my EKG, I wouldn't go straight to cardiac enzymes here. Remember, patient's laying with chest pain in the ER, and we'll talk about what should be happening to the patient. It wouldn't be drawing blood. It would be putting in an IV. And I say, well, while I put in the IV, I draw the blood, so I guess it's the IV going in first. You don't have to think second by second. You should think about what's most important in the management of this unstable patient. I'm not going to have the CPK or troponin levels back for several hours. This is a patient with chest pain who's having ongoing pain. The first thing I'm going to do is give him treatment for that. And we'll talk about that being aspirin, nitrates, and morphine as the things you'll do to start relieving the pain. But in terms of purely as a thinking through this exercise, in terms of diagnostic testing, we're going to need to see a CPK or MB. CPK MB fraction. Remember, CPK has 3 fractions. MB is the myocardial fraction. There's BB, which is brain fraction, and MM, which is muscle fraction. And we're only really interested in the CPK MB. CPK MB will start to rise within several hours of the myocardial infarction. It will peak by about 8 to 12 hours, and it will even start coming down by 24 hours, although it might remain somewhat elevated for some time after that. Troponin, which is a newer enzyme that's not even available, I don't think, in every hospital around the country yet, but it's becoming more and more available, is more expensive than a CPK-MB, but turns out to be a more useful test because, number one, it's more sensitive. CPK-MB might be normal in the setting of a real infarct, and the troponin level will be elevated. And number two, it's more specific. A troponin elevation is truly from myocardial ischemia, whereas a CPK-MB might be somewhat elevated if the patient's had recent surgery. There might be some overlap with the CPK muscle fraction. That's read as MB. If there's prolonged CPR, you might have a CPK-MB. The troponin is truly more specific for myocardial ischemia. The troponin level also rises fairly early, within the first 4 or 5 hours. It'll peak by about 24 hours, 18 to 24 hours, and it will remain elevated for longer than the CPK. So it's useful if a patient comes in a day or two after they think they had their chest pain that might have been their infarct. And on their EKG, it looks like they've already completed an infarct because they already have Q waves. In that case, if the infarct is suspected to be quite some time ago, not weeks, but I'm talking about at least 24 hours, a troponin level will remain elevated for a few days, whereas a CPK is really declining at that point. In the olden days, we used to look at SGOTs and LDHs and LDH subfractions. That's long gone. Troponin would be the best test because that will stay elevated for 2, 3, maybe even 4 days. Okay, now we're told in this patient, the CPK-MB and the troponin are both normal. So we got a guy who got a good story for ischemia, an EKG that shows ischemia, no signs of a Q wave yet, but normal cardiac enzymes. Now remember, cardiac enzymes are a dynamic process. This might be the CPK that you get back when the patient walks into the emergency room. And CPK or troponin measured 4 hours later might show that first peak. All right, so I have not ruled out a myocardial infarction so far. We'll do a chest X-ray because there are a lot of things that we had on our differential diagnosis list that would be diagnosed with a chest X-ray. But again, if this was the CCS, I'm not going to do a chest X-ray now. I want to pay attention to the management of his ischemia. Right? This is more of an overall discussion of how we evaluate patients with chest pain. His chest X-ray is normal, as it is in most patients with coronary ischemia, unless there's some other reason to have an abnormal chest X-ray. There's nothing about a myocardial infarct that will produce abnormalities on the chest X-ray. And because he's tachycardic, complaining of shortness of breath, chest pain, I might get an ABG. I would not get an ABG, on the other hand. I would not get an ABG if I'm thinking strongly about using thrombolytic therapy. And in fact, in this case, I'm not sure I want an ABG, because right now I'm thinking this guy might have a myocardial ischemia. And the most important single measure, not the first thing we'll do, but the most important single measure we'll do for a patient who's undergoing a myocardial infarction is giving them thrombolytic therapy to open up, bust open the clot that's forming in their coronary artery and potentially salvage them from having a myocardial infarction. But let's say there was a concern that this man might have a PE, even though in this case I really don't suspect it. Arterial blood gas is done. And again, it would be the wrong thing to do if you think you're going to give the patient thrombolytic therapy, because when you're doing an arterial puncture, that arterial site is very prone to bleeding if you're going to give someone something as potent as a thrombolytic agent. The blood gas is 747, PCO2 of 32. What does that imply? What kind of acid-base disturbance is that? Well, it's an alkalosis or alkalemia because the pH is higher than, say, 7.42. The PCO2, which is normally 40, is lower. It's 32. By definition, that means the patient is, quote, hyperventilating. Hyperventilation in terms of the pure medical definition or physiologic definition is that hyperventilation means your PCO2 is lower than it should be, lower than 40. Or let's say you're a COPD patient and your typical PCO2 is 50. When you hyperventilate, your PCO2 might still be above 40. It might be, say, 42, 44. But based upon what your baseline is, that would be considered hyperventilation. Now let's go back to this patient, 747, PCO2 of 32, O2 saturation is 96, the PO2 is 96, the O2 saturation is 99%. This man has a mild respiratory alkalosis. He's hyperventilating, but he is very well oxygenated. He would have a minor AA gradient, alveolar arterial gradient, were I to calculate it. The ABG here is not helpful, other than to tell me there's no significant pulmonary process. And again, I would probably have avoided it in a question such as this if this was a CCS question. Now, we went through a number of these clues based upon the history, and again, most of the time the history will give you the answer right there before you go into the physical exam. The quality of the pain is very important. If it's a squeezing, pressure type of pain, that suggests coronary ischemia. Yes, esophageal spasm or so-called non-cardiac chest pain can have the same feature, but it's usually going to be coronary ischemia, and certainly that's your most important consideration. If a patient shows you a fist on top of the chest, that's what's called a Levine sign. Dr. Levine from Mass General was a cardiologist, and in those days they had nothing much more than a physical examination and an EKG. And if a patient on morning rounds would say, Dr. Levine, I have pain like this, Levine would turn to the cardiology fellows and residents and interns and say, this man has coronary ischemia. And by and large, and even today, that tends to be the case. If it's a pleuritic chest pain, we talked about pulmonary embolus, we talked about pericarditis, we talked about pneumothorax. That's fitting that description. A tearing chest pain is pathognomonic, as far as you're concerned, for an aortic dissection. Does the pain radiate? If the patient says, I have chest pain here, and it goes down the right side of my body and causes tingling in my toes, that patient is probably a nut and doesn't have any coronary disease. You want to look for a physiologic or pathophysiologic pattern of pain. If the pain is here and radiates to the back, and especially if it has that tearing quality, what am I going to think of? Aortic dissection. If the pain is here, but also when I take a deep breath, I feel a pleuritic type of pain here, I'll think of pulmonary embolus or I'll think of pneumothorax. If the pain is localized here and perhaps radiates down my left arm, that makes me think of coronary ischemia. Radiates into my jaw, coronary ischemia. Radiates exclusively down the right arm, probably not coronary ischemia. All right? And letting the patient tell you where the pain radiates is much more useful in real life than saying, does it radiate down your left arm? Because they say, yeah, I guess so. Does it radiate into your left knee? Yeah, maybe. Don't lead the patient. Let them describe it, because often they'll describe something that makes it clear that it's not coronary chest pain. Risk factors. Let me just go back for a moment to the radiation of pain. If the pain goes between the shoulder blades and maybe has some tenderness in the right upper quadrant, something we didn't discuss, biliary colic, a gallstone getting stuck in the cystic duct. Again, it wouldn't be exertional. It would be related to meals. The patient will probably have other clues for gallstone disease. All right? So GI issues can cause chest pain. Pancreatitis pain is going to be radiating and probably more prominent in the epigastric region and going through to the back. Risk factors. They tell me a 22-year-old patient had the exact same presentation as my patient here. No matter how good her story is, coronary ischemia is going to be low down on my list. All right? Because coronary disease, except with rare exceptions, is not a disease of premenopausal women. All right? After menopause, women start to enter the same risk factor as men, especially if they're not taking estrogen replacement. But I want to look for risk factors. If this was a 42-year-old man, non-smoker, no family history, exercises, runs 3 to 5 miles every day, doesn't smoke, is at his ideal body weight, he has no risk factors for coronary disease. Can he have coronary disease? Sure. But it's going to be less likely than 68-year-old fat guy whose 2 brothers died at the age of 50, who smokes, is diabetic, doesn't care about losing his fatness and getting his sugar down, has a cholesterol of 300. That's obvious someone who's telling you that they have coronary disease. What are the associated symptoms? Diaphoresis, meaning the patient looks profusely sweaty, is a good warning sign that this is a hyperadrenergic state. Just tells me the patient's real sick, and certainly that fits for coronary disease. Shortness of breath, can it be with myocardial infarction? Sure. If there's left ventricular dysfunction, I can have pulmonary congestion and shortness of breath. Or I might just have anxiety from the thought that I might be having an MI, and I'll be tachypneic and look short of breath. Certainly it would be present in pulmonary embolus, it would be present in pneumothorax, it would be present in pneumonia, which we didn't discuss. There, the history is so different. It's going to be of fevers, rigors, usually a couple of days at least of pain, productive cough, and localized symptoms on physical examination. The chest x-ray will show you the pneumonia. You'll do a gram stain, sputum gram stain, to give you an idea of the organism and guide your antibiotics. Not something that's at all relevant in this patient. Palpitations can be seen in anyone. Someone who drinks an extra cup of coffee in the morning is going to have palpitations. But in the setting of chest pain, the onset of palpitations, more than just anxiety, is making me think about whether this patient is having an arrhythmia. Excuse me. A loss of a distal pulse, well, that's fairly specific for an aortic dissection. All right? If they're going out of their way in the question with someone with chest pain to tell you what their dorsalis pedis is doing, they're telling you, or even their femoral pulses, what they're doing, that they're asymmetric or different in timing than the radial pulses, they're telling you this patient has a dissection. Lastly, if this is a patient whose chest pain is clearly related to eating, they want you to think about pancreatitis, biliary colic, and esophageal etiologies. All right? Can people with coronary disease have their infarct during a meal? Sure. But again, that's not the same as telling you that the meal typically triggers episodes. Okay, how are we going to treat the patient who arrives in the emergency room, or this patient might happen to walk into your office, and the setting on the exam might be this patient arrives in the clinic or your office with these symptoms? What are you going to do for that patient? And again, at this point in this question, after all this talking I've done, I still don't know if this man has an MI or unstable angina. The next few minutes or hour or two will tell me. If the chest pain doesn't go away, it's already an hour, then I would fully expect the EKG to evolve, to have Q waves, and the CPK or troponin to go up. So far, his CPKs are normal, but again, it's still early. All right? Right now, if I had to make a bet, and I don't remember how this case turns out, I would say this man's going to have an MI. Just because it's already an hour, the story is so good for myocardial infarction. And remember, the acute treatment for unstable angina and MI is extremely, extremely similar. And we'll talk about the very few differences in a moment. What you're going to do for the patient with unstable angina or MI, first thing you're going to do is address these issues we have here: aspirin, morphine, and sublingual nitroglycerin. Intravenous nitroglycerin is not going to be the first step. First thing you'll do is you go to the patient and say, do you take aspirin? Did you take one today? If the patient says no, you'll give him a 325 milligram non-enteric coated aspirin. Tell him or her to chew it. All right, you're not going to lose points if you don't order chew aspirin on the CCS, but they'll chew it, it'll dissolve even quicker, and that is your first step, because that is directly addressing the problem they're having in their coronary. Morphine is going to be given at the same time. If the patient still has pain, you'll give them some morphine. How would I give the morphine? I hopefully by now will have an intravenous in, and I would give them intravenous morphine. Because the ongoing pain causes more anxiety, causes more adrenergic discharge, causes more hypertension, more tachycardia, and I've just described the perfect formula for more coronary ischemia. High blood pressure, tachycardia. That's the so-called double product, and is the determinant of myocardial oxygen demand. So if I could wipe out that pain, calm the patient down, tone them down, heart rate goes down, blood pressure settles down, my myocardial demand goes down. Morphine doesn't do a thing for my coronary artery. It's not going to open up that occluded artery, but it will reduce my demand for that limited blood supply. Furthermore, from a purely pharmacologic point of view, you should know that morphine has some venodilating effects. So it might have some minor benefit in patients who are also having left ventricular symptoms of systolic dysfunction resulting in pulmonary congestions. I'll pool some of my blood because it's a venodilator, and I'll therefore have less ending up in my lungs. Next, what I'll do is I'll give them a sublingual nitroglycerin because, again, it'll dissolve under their tongue, or I'll ask them to chew it, and then it'll dissolve even quicker. And that will hopefully give some coronary vasodilatation, which is of minor importance if a patient has an acute MI, because the problem is not one of vasospasm. What is the etiology? Because this will help you think about what is the approach to the management of a myocardial infarction. What is the etiology? What is the sequence of events that happens that this 68-year-old guy who's previously pretty healthy is getting a myocardial infarction right now? Well, what happens is in the coronary artery, the patient's had some long-standing plaque, cholesterol-laden plaque. That plaque has been stable. What happens is, for some reason, there's a tear or a fracture in that plaque, and that break open in that plaque attracts platelets. And the final step in occlusion of that coronary is not that the plaque has grown or the plaque has split open and blocked the coronary. It's that that plaque, which is, let's say, filled this much or this much or this much of the coronary artery, breaks open. That break in the plaque is an attractant for platelets. And platelets come and they start aggregating, and now I've totally, with the addition of those platelets, blocked that artery. So if I got room for just one more platelet to fit in there before I have total occlusion, giving that aspirin might prevent that last platelet. And aspirin might prevent that final step in that extra angstrom of occlusion of that coronary artery. So you want to get the aspirin in right away. All right? So immediately, we're going to give aspirin, morphine, sublingual nitro. We're going to start an IV. We're going to hook the patient up to an EKG monitor. And people often ask, do you give the patient oxygen? Oxygen used to be sort of a knee-jerk response. Patient comes in with chest pain, we put some oxygen on via nasal cannula. You certainly still wouldn't lose points for doing that, because many of these patients have some mild hypoxia with their ischemia. I'd rather give aspirin than put a little bit of oxygen on the patient. Certainly there's nothing wrong, even before you have an O2 saturation, giving the patient oxygen. And if this was a CCS question, after I've done aspirin, morphine, sublingual nitrate, I would administer oxygen in there too. Now, where do we really do the patient benefit? Where have we made the most progress in the last decade? How are we finally stopping the continuation of a myocardial infarction in progress? That has been thrombolytic therapy. That's probably the major advance in saving lives in coronary disease that we've had in the last century. Thrombolytic therapy gets into that coronary where it's already totally occluded. That last platelet has arrived and it's stuck, and now you have a totally occluded coronary artery. Thrombolytic therapy literally lyses the thrombus. It just breaks it open. And you get fragmentation of the plaque, and sometimes it goes downstream. It might cause little microinfarcts further downstream, and flattens out that plaque. And you again have recanalized or reopened that occluded vessel. All right? Now you say, well, why don't we use this in everyone? Thrombolytic therapy is not only potentially life-saving, ventricle-saving, ejection fraction saving, it's also life-threatening, because since it's such a potent agent in terms of lysing clots in the coronary, it could lyse things anywhere in your bloodstream, namely put you at risk for bleeding. And every large series of thrombolysis has a high, well, depends how you define high, has about a 1% risk of life-threatening bleeding. And that most commonly will happen in the brain. All right, patients, any large series has 0.6, 0.7, 1% risk of fatal intracranial hemorrhage. And about 10% of patients, you give thrombolytic therapy to 10 patients tonight, when you go back to the ER, one of those 10 is going to have a major bleed. Maybe not life-threatening, but let's say a major GI bleed. And we'll talk in a moment about the quick history you'll take if you're considering thrombolytic therapy. Thrombolytic therapy, now there are many different forms of recombinant thrombolytic agents. The two that I would be most familiar with is tissue plasminogen activator and streptokinase. Streptokinase has the advantage that it's much, much, much cheaper, maybe by a fraction of 100 or so, compared to TPA or any of the other TPA-like thrombolytic agents, but is slightly, minimally less effective than TPA. On the other hand, streptokinase is also allergic to some patients, whereas TPA is recombinant, it is not. Streptokinase is less clot-specific, so there might be a slightly higher risk of bleeding with streptokinase than TPA, which will hopefully focus more where there are significant clots, namely the coronary artery. They're not going to ask you to pick between TPA and streptokinase. Hospital formularies are still fighting about whether they should stock streptokinase or TPA. Because of pressure from patients that they want every last millionth of a percent of surviving, most places are using thrombolytic therapy. The one place you might be asked on step 3 to choose between the two is if the patient has had a previous MI where they've gotten streptokinase, since they've been exposed to it, even if they didn't have an allergy the first time, if they've been exposed to the streptokinase previously, they shouldn't get it a second time. The second time, if it's their second infarct with it requiring thrombolytic therapy, you're going to reach for the TPA. And we'll talk in a moment about what we should be asking the patient if they're a candidate for thrombolytics. What else will we do for our patient with MI? We're going to give them beta blockers unless there's a very specific contraindication. What are the specific contraindications for beta blockers? Very symptomatic signs of left-sided congestive failure. I'm not talking about just a couple of rails, but let's say there's rails at least one-third of the way up. Patient is markedly congested. You don't want to use a beta blocker in that situation. If the patient has an advanced heart block, you don't want to use it. If the patient has advanced or significant COPD or asthma, you don't want to use it because of its bronchoconstricting tendency. If the patient has really horrible peripheral vascular disease, beta blockers might cause some vasoconstriction there and make the peripheral vascular disease worse. So I'd be a little hesitant there. But on the other hand, I'd rather save myocardium than save the leg. They'll give you either a very clear contraindication, like a patient has very severe advanced COPD, or the patient has a complete heart block, or a Mobitz type 2 heart block, or a bifascicular block, where you don't use beta blockers. But in all other situations, they do want you to reach for a beta blocker. Why? Because it's very effective on the double product. Lowers heart rate, lowers blood pressure. All right? It's the most effective class of drugs to do that predictably. Work on both of those hemodynamic subsets. Now, let's say you have a patient who's clearly going through the throes of a myocardial infarction, and they have one of the contraindications to thrombolytics. They're at high risk for bleeding, and again, we'll discuss those risks in a moment. Those patients, do I have to watch them hopelessly complete their myocardial infarction because I can't give them one of my famous clot-busting drugs? The answer is no. Those patients who can't get a thrombolytic agent should be considered for what we call primary angioplasty, meaning angioplasty right here, right now, 2 o'clock in the morning, get them to open the cath lab, bring the patient up there, because then I'll be able to directly visualize the occlusion, the occluded vessel, and then I'll be able to hopefully open that vessel with angioplasty. And that, again, could be at least as effective as thrombolytic therapy in the acute setting. What other drugs should I consider in every patient have a myocardial infarction? ACE inhibition, especially if the patient has a low ejection fraction, or if you don't know the ejection fraction because you haven't done an assessment of that. If the patient has a large anterior wall infarct, the patient should get an ACE inhibitor right there in the emergency room or within that first day or so. If the patient has had normal coronaries before, no history of ischemia, no history of any infarctions, then I might hold off on the ACE inhibition. But they'll make it clear in the question. This is a patient who has severe heart failure. They want that patient to get ACE inhibition. So let's summarize everything we said about chest pain in a setting of myocardial infarction. Remember, overall, to summarize all our thinking about the approach to the treatment of MI, is I'm going to have 2 primary objectives. Number 1, I want to decrease the oxygen demand. All right? And decreasing the oxygen demand will not do anything to open the coronary, but it will equal out that balance between decreased supply, because the coronary is occluded, and even normal demand. If I could lower that demand, I'm making the risk of oxygen depletion less in those myocardial cells. What's the most effective drug for diminishing oxygen demand? Beta blockers. Also, relief of pain with morphine will reduce the blood pressure, will reduce the heart rate, and lead to reduced oxygen demand. And just as importantly, or maybe you might say more importantly, is get that coronary artery open. All right? In this day and age, thrombolytic therapy should be thought of as first-line therapy, should be thought of as every patient presenting early to the emergency room. Who's the most likely to benefit from thrombolytic therapy? People with the larger infarcts, because they stand the most to gain, and the sooner they're coming in with their chest pain. This guy is ideal. He's only had chest pain for 1 hour. If it's beyond 12 hours, let's say, I'm going to be very reluctant to give the patient thrombolytic therapy, because what I will assume is that most of the damage is already done. That area of myocardium is already infarcted. Opening it up now will not do much. And so therefore, why will I expose the patient to this tremendous risk of bleeding from thrombolytic therapy if I don't have much to gain? So it's basically someone with less than 12 hours, and ideally within 1 hour of coming to the emergency room. That's what I'm going to use thrombolytic therapy for. And I'm also going to start reestablishing perfusion by giving heparin with the thrombolytic therapy. Okay? Because I don't want that recently reopened vessel to reocclude. The medications, we're going to use TPA or streptokinase for thrombolysis, and they have a similar efficacy. They do significantly reduce mortality when used within 6 hours. The sooner you use it, even greater is the reduction in mortality. And again, there's very little benefit if I use it more than 12 hours after the infarct. What are the contraindications? Well, they're fairly intuitive. You don't have to memorize the list. Think about those things that puts the patient at higher risk of bleeding. Have they had recent GI bleeding? Have they had a history of intracranial hemorrhage or recent head trauma? Let's say they had syncope with their myocardial infarction, fell and banged their head against the ground. That patient, even if I know for sure they're having a large anterior wall, I will not give thrombolytic therapy because I might immediately cause them to bleed into the head and die. If they've had recent surgery, that's a higher risk time period where you could get ischemia. You've just had surgery and the stress of surgery. If you had recent surgery within the last few days, especially, thrombolytics are relatively contraindicated. If I have severe diabetic retinopathy, it's relatively contraindicated. But I have to warn the patient, if you have neoproliferative vessels in your eye, neovascularization, as opposed to the hard exudates you might see with chronic diabetic changes in the eye, if you have proliferative vessels in your eye, those vessels might bleed and might cause blindness. And then you have to wonder about the risk-benefit of blindness versus saving myocardium and maybe saving his life. So it's a relative contraindication. And if the patient has a predisposition to bleeding, if they have some underlying bleeding disorder, certainly I would be very, very cautious about the use of thrombolytic therapy. And we'll take a break here.